Esophageal diseases. The anatomy of esophagus, all we know that comes, it's the food pipe that we know. We got the esophagogastric junction, which is critical in pathogenesis of any esophageal diseases, important in the reflux and the motility disorders. Esophagus is divided into cervical, thoracic, and abdominal part. It's made of inner circular and outer longitudinal muscular layers. The proximal third of the esophagus is striated muscles, so it means voluntary. And the transition, then it will transition the last 2/3 into smooth muscle, okay? The proximal esophagus contains upper esophageal sphincter, which comprises of the cricopharyngi and the cricothyroid thyropharyngeus muscle. سكروا الباب يا شباب وراكم. سكروا الباب وراكم وممنوع حدا يدخل. سكر الباب وراك يا دكتورة. ممنوع حدا يدخل بعديكم. Okay. Next, the distal thoracic esophagus is located in the left side of the midline. So الكورس وهو ماشي بروح toward the left more بيكون ببلش in the midline then goes toward the left because of the heart. As the thoracic esophagus enters the abdomen, the esophageal hiatus by the diaphragm becomes more. So once it enters the diaphragm, it's called the abdominal esophagus. The hiatus is formed by the right cruri, which means the right cruri of the diaphragm, which forms a sling around the esophagus and with the right and left pillars. So the esophagus narrows when the diaphragmatic contracts, and this is a functional sphincter called gastroesophageal sphincter. So anatomically, ما في sphincter, but it's a functional sphincter. Next. The actual contribution of the diaphragm provides maintaining the adequate length of intra-abdominal esophagus is not clearly understood. However, identification and approximation of the pillars during the surgical treatment is crucial for preventing the reflux disease. That's why we'll put a slide about how anti-reflux surgeries can be done. The acute angle and the length of the abdominal esophagus helps to the normal contribution in the normal closure of the esophagus when the intra-abdominal pressures they are high. They will push up because of the acute angle. They will push up the stomach, and it will be more horizontal. So, with the length of that, they will close tightly, functionally as a sphincter. Okay, next. The motility and the tonic, the upper esophageal sphincter, tonically closed, opens 0.2, 0.3 seconds after the swallowing to allow the bolus of the food to go down. Peristaltic contraction, as we know, duration less than 7 seconds, and the amplitude is 100 millimeter mercury. These numbers come from manometry or something called impedance test, when you put probe down in the esophageal with multiple probes to measure the pressure and the gastric and the acidity. They will give you a couple of numbers and peristaltic activity. Lower esophageal tonically closed at rest, pressure 20 milligram, cholinergic mediated relaxes with the swallowing. That's quite important because anticholinergic will cause sometimes reflux. Next, diseases that affect the lower esophagus and the esophagus in general are achalasia, esophageal hiatal hernias, and GERD, gastroesophageal reflux disease. Next, achalasia is a motility disorder, basically characterized by the absence of the esophageal peristalsis and impaired relaxation of the lower esophagus in response to swallowing, usually because of the mesenteric plexus within the esophagus, the lower third of the esophagus, or absence of the mesenteric plexus, which is found, as you remember from the anatomy, in the submucosa muscularis area that innervates the muscularis to contract. Okay, then the lower esophageal sphincter, the relaxation, there will be impaired relaxation, high pressures down there. Okay, is hypertensive in about 50% of the patients. The abnormalities causes functional obstruction in gastroesophageal junction. Next, please. Idiopathic sometimes, some like cancers, pseudochalasia, Chagas disease, which is Chagas disease, if you remember, caused by trypanosoma. We have two types of trypanosomas. One causes serum sickness or sleepiness disease, more in Africa, and the Chagas one that's this bug that's the trypanosoma that's more common in America, North America, if you remember, and Middle America. It causes Chagas disease, which affects the heart and affects the esophagus as well. Okay. So next, dysphagia. Odynophagia is less common. Dysphagia, difficulty in swallowing. Odynophagia, painful, it's less common, to be honest, because there is no such structures there. Equal difficulty swallowing for liquid and solid, so both liquid and solid, because we need coordination. We need a nervous system to coordinate in order to drink well. Okay, the solid thing, the bolus uses usually the gravity to go down. So, and because the sphincter is closed, so both of them, they will not go. Bolus cannot go down. It's the way mechanically obstructed, and the fluid cannot go down because we need a coordination, neuromuscular coordination for that. Okay, esophageal cancer dysphages for solids is greater than liquids. لما يكون في عندنا masses usually دائما mechanical obstruction causes more solid obstructions. Regurgitation, chest pain, weight loss, recurrent chest infection, aspiration, especially when they lie down, and usually often they have bad mouth smell, halitosis. Okay, next. Barium swallow, beak paired appearance will be, so contraction peristalsis, like in the segment that's not supplied by the mesenteric, loss of its nerve supply, there will be like a beak paired. Esophageal manometry, as we said, is the standard for that. Incomplete lower esophageal relaxation, response to swallowing, high resting pressures within the sphincter, absence esophageal peristalsis, and we need, when we see that, for the completion of the workup, we have to do an endoscopy, because we don't know. The manometry will show you that, but cannot say to you that there is a cancer down there. Okay? Next. This is the beak pad we talk about, absent, and the proximal part is dilated as well. Next. Due to the reflux, you can see this, the esophagus due to the reflux. This is due to the severe reflux of the gastric content and the fluid. Next. This is the manometry here, and the esophageal sphincter is, the pressure is very, very high here. It will be should be lower than that. Okay, and you can see the movement, absence of movement, almost absence of movement here. There should be more amplitude. Okay, next. Management, what we should do for achalasia, we ask them to have multiple small tiny snack, يمضغ كويس, eat slowly. Okay. Chew food thoroughly, drink plenty of water. That would help make the bolus more bulky in order to open and allow the gravity to open even this narrow segment. Okay, sleep with the trunk elevated. ما بدنا يصير عندهم reflux and aspiration, recurrent aspiration. Avoid eating before sleep at least 4 hours, and avoid anticholinergic drugs. You should review all this stuff, caffeine, take, and all of this stuff that might cause. Medical therapy. Antimuscarinic effect might be given. Nitroglycerin might, all of these that cause smooth muscle relaxation might help. Calcium antagonist and antimuscarinic and GTN. That's why sometimes when you remember when patients present with esophageal spasm, the sublingual pill helps. Next. Endoscopic injection of botulinum. So if all of these measures did not improve the outcome, we refer them to the GI consultant or the specialist would be treated for injecting botulinum toxin that will relieve causes the relaxation there at specific areas at the sphincter and the segment. It's effective in 2/3 of the patient. Sometimes we do forceful dilatation, but bear in mind with balloon, with the endoscopist, and bear in mind the risk of perforation. Doctorat, no side talks, please. Surgical Hilliard's myotomy, because this area is just a muscle that's not innervated and it's causing issue, we just go there and remove the muscular area, the muscular layer. Okay. For those who do not respond, so they usually surgery is the last resort. دائما بأي شيء. If you can't treat medically, treat medically. If you can't, that's surgical. Okay. وما تطول على المريض يعني. Next. This is the lower esophageal sphincter, esophageal dilatation, positive, this is how hilar myotomy they approach it. Next. Esophageal hiatal hernia, we have two types of hernia. Sliding hernia, the most common, account for 90% of the cases when both gastroesophageal sphincter junction and the portion of the stomach, they herniate into the thoracic cavity, okay? And the esophageal, so the gastroesophageal junction is above the diaphragm. This is more common, very common, quite common, and it's finding associated with GERD. The other hiatal hernia is the baroesophageal, which is gliding to the where the part less than 5% stomach herniate into the thorax through the esophageal hiatus, but the gastroesophageal junction, it will be sliding side to side with the esophagus. We'll see in the picture now. It remains below the diaphragm. This is uncommon hernia because it can be strangulated and should be repaired surgically. Okay, next. So this is the pictures. Normal esophagus, sliding hernia most common, and this is the baroesophageal hernia. Can be strangulated easily, and often we need to treat this surgically if it's too large. Okay, sliding hernias, it's quite common. نشوفها كثير incidentally in CTs when you do CT scan for chest lesions, sometimes for a reason and another, and you find sliding hernias. Either if he's symptomatic, GERD and this stuff, you treat him and medically optimize him. We don't often, unless it's very severe. We'll go through that. Clinical feature ranges from asymptomatic again to debilitating life symptoms like heart pain, chest pain, dysphagia. Sliding hiatal hernias include GERD, the most common reflux esophagitis with the risk of Barrett's esophagus that result from recurrent and prolonged exposure to the gastric juice. This will cause a metaplasia, still not a dysplasia, but it is important. And if it's meant to be to go toward dysplasia, he might develop esophageal cancer. Okay. Aspiration, paraesophageal hernias, they are at risk of obstruction, strangulation, incarceration, and hemorrhage. Next. Diagnosis. Number one, barium swallows or barium follow-through. Follow-through, we don't need it. Barium swallow. Barium upper GI series and upper endoscopy. Next, please. Barium, you can see we can see the hiatal hernia, the part of his sliding hiatal hernia. They will do a series. They will ask the patient to drink the barium, and they will do it will be done in the fluoroscopy, live, real-time live fluoroscopy. So they keep having multiple pictures, and then they will release it as continuous film, so you can see how the bolus and the contrast is going down there, and where is the issue and where is the problem. Okay, next. And once we see that, we would rather do, after that, refer him and do an endoscopy. This is where the hiatal hernia, the sliding and sliding. This is the Barrett's esophagus because of the recurrent, the changes in the epithelium. We have to keep an eye on that. Next. Treatment type 1, medically, small meals, antacid, elevation of the head, no coffee drinks, and all these things. If it's severe enough, if they are not responding, as they mentioned here, 15% of them, they do not respond, we go toward Nissen fundoplication. We will give you about what slide about the Nissen fundoplication, what does that mean. Type 2 hernias, elective surgery. Usually we do elective surgery. ما بدنا إياه يجي emergency مرة من المرات بالليل هو strangulated, perforated, or hemorrhage. But if you catch it, just ترتب معاه electively. Do it as electively. Day case 1-2 days روح بسلامتك. ما بدنا يجي presented at night. Bear in mind, especially the طبعا. This is the Nissen fundoplication. This is where we were talking about the pillars. So part which is part of the diaphragm that subhanallah يعني احنا نفكر انه كل شيء له قيمة يعني ربنا خالقه. We use them in the fundoplication as making a functional sphincter, restoring the functional sphincter functionality. Okay. Next. A gastroesophageal reflux disease. Reflux is gastric contents in the esophagus because of the relaxation, sudden relaxation of the esophageal and loss, and the tone is low within the gastroesophageal junction. Any significant symptomatic condition, histopathological changes from reflux, like reflux esophagitis. GERD, patient with histologically demonstrable changes in esophageal mucosa. That's quite important. Next, please. Pathophysiology, primary barrier to the gastroesophagus is the lower esophageal sphincter. When it's not working properly, the barrier is disturbed and the gas comes from the acid to the stomach, causing a lot of problems for us. Next, please. Okay. Symptoms: heart pain, retrosternal pain, sensation, regurgitation, effortless return of gastric contents to the pharynx without nausea, retching, or abdominal contraction. Dysphagia. Heart pain is quite common as they might present acutely with pain. Less common chest pain, water brush, increased salivation because the gastric juice, when they will read the oral cavity, they will keep salivating. Globus sensation, the patient will feel that there is something within the sore throat. This is called the globus hystericus previously. So when usually they present either to us or to the ENT doctors, and often they will start them in BPI. Sometimes because of the reflux as well, the patients, they might have hoarseness of voice. The ENT doctors, they will put they will do a laryngoscopy, direct laryngoscopy. Why? With endoscope, they see a lot of redness on the vocal cord. They will prescribe BPIs because they know that this is a reflux, due to reflux. And patient with odenophagia nausea, patient with asthma, their asthma, they will be not controlled or poorly controlled because of the reflux. So one of these things that to make sure and to bear in mind when a patient with asthma and you're treating him optimally, medically optimize his asthma medication, and still he is symptomatic, you should bear in mind the reflux, that the reflux will cause chronic cough irritation and asthma worsening. Give him BPIs, treat the reflux for him, and eventually his asthma or hair asthma will improve. Next. Evaluation. It's classic symptoms of heartburn, regurgitation, the same. Alarming symptoms, almost the same that we mentioned before. Unintentional weight loss, pain at night, iron deficiency anemias, all of pain radiating to the back sometimes, all of these stuff, not responding to medical treatment, previous history of family history, for example, of cancers in the gut in general, يعني ما تسألوش just عن esophagus, أنه ممكن يحصل wherever this is a mutations. This is quite important. Alarming sign, dysphagia, early satiety, GI bleeding, onginophagia, vomiting, weight loss, iron deficiency, anemia. This is quite important, bear in mind. H2 blockers and BPI are the classical treatment, 2 to 4 weeks, no response, change, upgrade, titrate, maximize by 2 instead of by 1 BPI, and if no improvement, please refer him to the specialist. You would need 24 BH manometry monitor to monitor if there is a reflux, and probably an endoscopy to see if there is any changes in the mucosa and see if there is any hernias, any structural causes for that. Please, thank you. Next. Anti-reflux surgery, failed measurements, failed medical treatment, patient preference, shared complication. ما بده يضل رايح جاي على الدكاترة. He needs a definitive treatment. You can offer him a surgical treatment, but you have to mention that it might come maybe after a couple of years, and success rate probably reaches 70-80%. But if he gains weight again, for example, and if he's eating a lot of carbohydrate, حلو كثير, هاي الأمور, he might have still some heartburn and symptoms might reoccur. So yeah, will reduce the burden, the symptoms بنسبة كبيرة, 70-80-90%, who knows, لكن it might reoccur. Okay. A medical complication attributable to large hernia, زي ما حكينا, you send them to the surgery electively, خاصة the paraesophageal. Atypical symptoms with reflux documented in 24-hour pH monitoring. يعني في عنده symptoms but وجدنا في pH monitoring إنه عنده reflux. We treat the reflux, though it's atypical. Treat the reflux first, then or we send them to the surgery to see what's going on. Either endoscopic treatment, there is an endoscopic treatment for the reflux, radiofrequency application to increase the lower esophageal sphincter reflex barrier. So radiofrequency might stimulate the nerve ending there and restore the اللهم صل على سيدنا محمد, the activity of that sphincter. This is part of it. This is the endoscopic. بيعملوا stabiler. They have a stabiler within the endoscopy. بيكملوا زي ما بتعمل الكم. You fold it and you stable it, and this like you do like an anatomic barrier now, like a structure, a new sphincter, because you take the fold from the stomach that have a proper lower muscle, contracting muscle, and you make it like a new sphincter. So, and there is a barrier, so that won't be easy for the gastric juice to come back because there is a barrier, mechanical barrier first. And I do like the same way, you increase the angle now, it's more acute probably, and it's more resembling the normal occurring sphincter. Next. Paired complication, erosive esophagitis, stricture, Barrett's esophagus, erosive Esophagitis responsible for most GERD symptoms. Severity of esophagitis not in line with severity of symptoms. This is more an endoscopic severity index. يعني الاندوسكوبيك هو اللي بحكي لنا how severe A, B, if there is erosion, C, if there is more bleeding associated. So they will write either gastroesophageal reflux disease or non-erosive NERD reflux disease. So not all reflux diseases should cause erosion. Some of them they will do. Next, please. Esophageal strictures that will result from recurrent esophagitis, erosive esophagitis, and healing. So not proper healing sometimes will lead, or excessive healing might lead to strictures, fibrosis, and narrowing. And rarely, very rarely, they might need dilatation by endoscopy, balloon. Barrett's esophagus, when there is a columnar metaplasia of the esophagus, usually we have cuboidal epithelium and squamous epithelium, but when they change to abnormal columnar, this is called Barrett's esophagus. They might, very rarely, they might progress into dysplasia and cancer on long-standing, untreated gastroesophageal reflux disease. Next. Yes, this is the histopathology of that. Original squamo-columnar junctions, the same repetitive epithelium injury, and eventually we'll have this type. The pseudocolumnar will change into pseudocolumnar. Okay, next. Normal healthy esophagus on the left, esophagus damage of prolonged acid exposure, gastroesophageal Barrett's, long-standing, dysplastic Barrett's, and the most worst case scenario is esophageal cancer. Next, management of Barrett's, managing of the GERD reflux, treat antacid, upper endoscopy surveillance every 3 years, patients without dysplasia, those with high-grade dysplasia yearly, maybe less than that, but it should be yearly. And usually we do a 4-quadrant biopsy. بنعملهم كانهم 4 quadrants الاسophagus, and we take biopsy from each quadrant to make sure that everything is. And those with high-grade dysplasia and they have a lot of risk factors, we will send them to elective esophagectomy للأسف. Any questions? الله يعافيكم يا شباب. Any questions? Hope. أنا عارف إنها lengthy day. Take a break قبل ما تيجي دكتورة غيداء.